So, Wilhelmina, we'll turn the microphone over to you to present your cases, and we'll have some discussion.
Thank you, Dr. Hassel. Can everybody see that? The presentation?
Yes.
Okay, thank you. All right, so I'm presenting only one case, and this is case number 5. Good morning to everyone. Hello, Dr. Karen. It was nice to meet you during the pathology update just beginning of
It was
this
great
month.
to meet you too, Velo.
Also, I thank you to Felicity for helping me upload my presentation. It's quite heavy because of all the photos that's attached with it. So in the iEcho platform, there are 5 parts to it, but in this one, there's only one part because it's all in one. Okay, let's begin. So this case is a case of a 55-year-old Nulliparous indigenous female who presented with unintentional weight loss and progressive abdominal distension over a period of 3 months. She also complained of associated reduced appetite as well as early satiety. However, she denies having any fever or having any bowel symptoms or having any urinary symptoms as well. She had a menarche at the age of 13, menopause at the age of 51. She has a history of smoking as well as cover consumption, which she stated that was discontinued 2 months prior to presentation. She actually presented to a healthcare facility that is close to our main hospital, and then she was referred to us due to what they found on ultrasound scan. So on physical examination, she is comfortable. Hint and chest examinations were otherwise unremarkable. Abdomen on palpation, it was soft and there were no palpable masses. On gynecological exam, through speculum, they saw that the cervix and the vaginal vault were both normal and no bleeding was noted. On vaginal examination, they noted that the cervical was closed. CET was negative, but they felt a palpable left adnexal mass, and at that point in time, they figured that the pouch of Douglas was not full. So they ordered an array of blood results as well as imagings. The only outstanding blood result that I could find was the CA125, which was 1029. LDH was slightly elevated, CEA was otherwise normal. On ultrasound scan, they found a lobulated complex mass on the left adnexa with a cystic right adnexa, but the uterus was not visualized. So the assessment at that point in time was a nulliparous 55-year-old menopausal female with bilateral adnexal mass for further investigation. She was then sent to our gynae team here at Lancaster Ward, and then she was seen accordingly. She was then taken in for an operation, and these were the intra-op findings. Intraoperatively, they found a left ovarian tumor, and they identified that it had invaded into the distal sigmoid colon. So at that point in time, they did an abdominal TAH as well as a mental biopsy. They also removed sections of the sigmoid colon that they felt was invaded with tumor, as well as a peritoneal fluid sampling. This image that you see here on your right is just a ChatGPT image of what the surgeons might have seen during the operation and the proximity of that left adnexal mass to the distal sigmoid colon. So a bit different from the previous presentations, with every microscopic evaluation, I've also attached the microscopy visual photo as well. So what was received in our histology lab was a TH specimen. This is exactly how it looks like. You can see that the cervix is pale white, and there is this identifiable mass on the left adnexa, and this is the right adnexa. So you can tell that there's something abnormal that is happening. The cervix measured 30 millimeters in maximum diameter. The left adnexa measured about 80 by 90 by 60 millimeters. It had a pale white lobulated appearance. The right adnexa was dilated, had a darker gray appearance, and measured 90 by 40 by 50 millimeters. The uterine corpus was otherwise unremarkable. It measured 50 by 40 by 20 millimeters. So on closer inspection, this is the posterior photo. This is the posterior surface of the uterus. As you can appreciate, this left adnexa is more adherent to the lower uterine posterior segment of the uterus. And upon cutting, this is what the mass of the left adnexa looks like. It has a variegated pale white appearance. It was very friable, and you could actually appreciate the membrane or the cystic capsule. So on microscopy, this is what was found for the left adnexa. We can appreciate that it is a cyst capsule and a cyst wall. This is the wall, and then we can appreciate these trabeculae and nests of malignant cells. On higher magnification, there is marked nuclear pleomorphism, high ANSI ratio. There is abundant mitosis. In other areas, there were some homobodies. This is a high magnification of that same photo. Very discohesive, patternless. In some places, we could see papillae, but other than that, the cytology, the morphological cytology appearances was very, very dysplastic and very pleomorphic. There was a florid LVSI was noted. This was one of them. Bigger vessels were also seen with LVSI in them. So upon cutting the uterus, this is what was found. This is the left adnexal mass. This is the posterior surface, and you can see that there is direct invasion or extension into the lower uterine segment, into the myometrium, but sparing the cervix as well as the endometrium. So the photo on your right is just a high magnification of the photo on the left. You can appreciate that there's some hemorrhage. It's there with some solid areas and some invasion that you can appreciate that's also there. So this is the microscopy of that invasion, just demonstrating the cervix as well as the endocervical canal and the transition. So the transition of the slide is from your left to the right, and then it comes down. So the first one is just Nabothian cysts, which is something that we see commonly here as well. There's some increase in epidermal dermal junction infiltration of lymphocytes, but other than that, nothing else was remarkable. And the most things that I wanted to show here was the last photo at the bottom, which showed a direct infiltration from the outside into the cervical stroma. This is from the myometrial aspect. The serosal surface is what I'm trying to show here on the first photo that you see. And you can see that there is this mass effect of infiltration of malignant cells coming from that is there within the myometrium. But as we move on further onto the slide, we can appreciate that these malignant cells are actually coming from the outside into the onto the serosal surface of the myometrium, of the uterus, and into the myometrium. So the last photo is just demonstrating that there's a lot of tumor necrosis as well. Some homobodies you can appreciate, and there's a lot of mitosis and hemorrhage. The bowel segment that was received measured about sorry, 55 by 118 millimeters in length. The mucosa is the one that's posterior in the inferior margin here on the slide. So this is the posterior surface of the bowel that was resected, and this is the serosal surface of the bowel. So we can appreciate that the cut surface shows a solid mass within the coming from the serosa into the submucosa, into the muscularis layer as well, sparing the colonic mucosa. This is the microscopy of what we have just seen. So we can appreciate that the colonic mucosa is normal, and there's this cohesive large mass that is infiltrating from below into the submucosa. The photo on your right is just demonstrating the morphology, the cytological atypia that is seen within the mass that we are seeing as well. So there's abnormal mitosis that we see. Again, the same thing, very vesicular nucleus, marked nuclear pleomorphism, high NC ratio, and you can appreciate that there's some inflammation that is happening as well as necrosis. The omentum that was received measured 10 by 40 by 8 millimeters. I could not palpate any nodes at that point in time, but however, on microscopy, we found multiple focus of malignant infiltration. You can see here the surrounding adipose tissue, and there's a nice round lump of malignancy or metastatic malignancy that is present within the omentum. So this one right on your right, far right, is the high magnification of that metastatic malignancy that we've seen. The acidic fluid that was received also showed similar things. Clusters, a lot of clusters of these malignant cells, and on higher power, we can actually appreciate them attempted to form glands at some places. But similar cytological morphology. Marked nuclear pleomorphism, nuclear hypochromasia. We could see a lot of mitosis, even bizarre mitosis, high NC ratio, and attempted gland formation. So what did our pathology report look like? This is the actual pathology report that we have. At this point in time, we hadn't included our AJCC staging. So just the same things that I've said already. Mitosis at the for the specimen was more than 20 mitosis per 10 high power field. Lymphovascular invasion was present with obvious capsular infiltration. So the omentum in the sigmoid colon was also involved. So when it came to the AJCC MTNM staging, we had a thorough discussion with Dr. Viri, who is my overseeing consultant, and we came to a conclusion that this is a high-grade serous carcinoma of the left ovary with lymphovascular space invasion, tumor infiltration involving the right ovary, the myometrium, the sigmoid colon, with omental metastatic deposits also present. So our pathological staging was H3C, PT3C, and O, but M1. M1, M1B, because there's transmural involvement of intestines. So what was the clinical impact and management concerns of the issue? I believe before the TAH was done, when they had done the CT scan as well as the ultrasound scan, there was a debate on whether they do neoadjuvant therapy or adjuvant therapy. We were fortunate enough that at the time the visiting team was here from New Zealand. So they managed to take this case in. That was how I was able to receive the specimen last year. And thereafter, they did adjuvant chemotherapy. At this point in time, unfortunately, the patient's CA125 hasn't been very promising. February, it was 1279. Just a few days ago, when the patient came for clean, it has risen by 500, so it's now 1761. Yes, that's all. Thank you.
Well, excellent presentation, and very common disease with fairly classic presentation, but obviously some very unique characteristics to the discussion. Karen, do you want to lead off, or do you want to open it to questions here from our group?
Yeah, sure. First of all, if there are questions, please speak up. I've got a question. I'm interested, Viri, to know what was in the contralateral ovary and what was in both fallopian tubes. Did you find any pathology there? And also the endometrium. I know you showed us the histology report, but I didn't manage to see all those details.
The endometrium was normal. The right
It looked
ovary had the tumor
like there was a
infiltration.
polyp macroscopically. That's why I
Yes,
asked.
there's a small polyp that is there. Yes.
Yes. And sorry, the fallopian tubes and contralateral ovary, what did they show?
They had tumor infiltration all throughout for both the right and the left adnexa, ovary and fallopian tube.
So the wall of both fallopian tubes also involved, or the mucosa, or both?
Both. Hang on, Dr. Karen, let me read it. Okay, so the left ovary showed that high-grade serous carcinoma. Unfortunately, I don't think we had mentioned anything about our right. We'll have to go and review that one.
It's really just out of curiosity, just to,
Yeah.
and I guess there's a kind of a reason I'm pursuing that line of questioning is it's always interesting to look at the fallopian tubes in the context of a high-grade serous carcinoma, which is presenting as an ovarian mass primarily. And do you know why that is?
Because usually ovarian cancers they say that it's from the fimbriae of the fallopian tube mostly.
Absolutely. Yeah, correct. And it can be important. Well, probably the primary importance is, a couple of things. It helps you type it, as if you're really struggling and you don't have immunohistochemistry, and you have a clear-cut stick lesion in the fallopian tube, that would help you navigate towards a serous diagnosis. But it also is important in terms of site of origin, designation of the site of origin. Not that that really has any impact on patient care, but if there is mucosal involvement of the fallopian tube, in this context, we would regard this as a tubal primary.
Dr. Karen, I just saw the microscopy. So both fallopian tube shows tumor infiltration, and sections of the right ovary shows corpus albicans with serosal surface, showing tumor seedling.
Yeah, which is a really common scenario in this context. This was a really high-grade looking malignancy in parts. Like, there were areas where if that's all you had, you would struggle to type it. And I guess I'm interested in how you nailed the diagnosis of a high-grade serous carcinoma. You did mention a few additional features when you were describing, but maybe if you could expand a bit on what the morphologic clues are when you're dealing with a high-grade malignancy. First, that lead you down a pathway of carcinoma versus differentials like melanoma or sarcoma. And then how do you arrive at a diagnosis of a high-grade serous carcinoma? Just on the morphologic grounds. We obviously have an array of immunos we can use in that context. But if all you've got is histology, what are the features that you use to help you navigate that diagnostic process?
In terms of morphology, the high-grade cytological atypia was one thing that threw us off because that's not what we usually see in other types of carcinomas. Yeah, we did see some of the bodies in some places, but the majority of the places that we saw, there was just so much cytological atypia that for us, it was nothing else but serous carcinoma since it's the most highly with that much of cytological atypia. But that was the only key indicator for us that it was a serous carcinoma, a high-grade serous carcinoma. It was just that high-grade cytology for us. Apart from the necrosis and the bizarre mitosis, it was the high-grade cytological atypia.
Yeah. So almost by exclusion, I guess you're saying no other tumours look as ugly as a high-grade serous carcinoma. Were there any other clues? I know you said somoma bodies, but I thought there might have been a clue in the very first histology section you showed a photo of. Maybe if we go back to that.
It's interesting. This question has come up in several of our other echo sessions about, based on pure morphology, how you arrive at the diagnosis of serous carcinoma, which I think is a pertinent question for settings where your immunohistochemistry is costly or only sporadically available. And one of the things that was mentioned by Rob Soslow is the degree of nuclear pleomorphism. And when you see a range of sizes that is greater than 3:1, that's a fairly strong indicator that it's going to be serous carcinoma, a high-grade serous carcinoma versus low-grade serous carcinoma. So I think that's one of the clues that we should highlight here. And then I think you'll talk a little bit more about the cystic changes and so forth.
And the other thing is a high mitotic rate.
Yeah.
Typically with a high-grade serous carcinoma, I think they say more than 12 mitotic figures per 10 high-power fields is required or is classical. You can usually achieve a count of 10 mitoses in a couple of high-power fields with a serous carcinoma. But say the differential of a clear cell carcinoma was being contemplated, which can also show high-grade atypia, you generally don't see that striking a mitotic rate in a clear cell carcinoma, for instance. So yeah, there were some subtle features here that I thought suggested carcinomatous differentiation. I thought that there's some cohesiveness of these cells and maybe some little cleft-like, tubule-like spaces, sort of sieve-like glandular spaces, which is one of the characteristics of serous carcinoma, is those sort of slit-like or sieve-like glandular spaces. I appreciate this might just be the cells falling apart, but it sort of struck me as potentially having that glandular differentiation here. Is that how you interpret this, Viri, or is this just cellular disc adhesion and clefting in the tissue? Sorry, did I say Viri? Vilo, I meant.
I think they look real to me.
Yeah, there's also a couple of sort of elongate gland-like structures in the wall immediately beneath the surface of that luminal growth, that luminal component. But yeah, I guess first, I guess, the first principles, the first.
Sorry, Dr. Karen.
That's okay. The first decision point when you're dealing with a tumor like this is carcinoma versus lymphoma versus sarcoma versus melanoma. And how are you going, what morphologic clues are you going to look for to help you make that decision? And I thought this particular slide had a hint of epithelial differentiation to it in that the features I just described.
Yes. So we saw solid sheets, nests of malignant tumors that were highly pleomorphic with enlarged vesicular nuclei and macronucleoli. We saw numerous atypical mitosis with substantial lymphovascular invasion, as well as that carcinoma-like in situ pattern, the sieve-like appearances that you had mentioned. We saw quite a good number of it.
So there's a few things there. Solid, so cohesion of cells, nested, sieve-like architecture. As soon as you're seeing cohesive growth of cells, and I think that was also represented in the deposits in the lymphatic channels, they're all clinging together and solid nests. I think you can put a line through and cross off lymphoma and melanoma from your differentials. So these are really basic things, but they're important when you don't have immunohistochemistry, when you're dealing with a really high-grade anaplastic-looking neoplasm. So it sounds like you made that decision fairly comfortably that this was a carcinoma. And then we've talked about the features that help you land on serous carcinoma. But yeah, I think when you're dealing with a high-grade, really ugly-looking tumour like this, there aren't too many things it can be when you're in the carcinoma ballpark. And I mentioned clear cell. That's probably the only other real contender in terms of carcinomatous differentials. Grade 3 endometrioids can look quite atypical, but this isn't presenting in a classical way, I guess, and that would be unusual to have a completely high-grade anaplastic-looking morphology. Any other questions or comments from anyone else?
Well, I have a question about this particular field because the degree of lymphatic and vascular space invasion that she's shown us, in my experience, is a little bit unusual with classical ovarian serous carcinoma high grade. Because as we look at the research and so forth into this tumor, it's not something that likes to spread via vascular or lymphatic channels. It's primarily an intraperitoneal disease, and it only rarely develops this capacity for vascular spread and invasion. And that's why they don't typically do node evaluations and so forth, but they'll do extensive peritoneal staging biopsies. So I guess my question is, Karen or others, do you think that this degree of vascular space invasion portends a worse prognosis in this patient? And should they be concerned about nodal or other, hematogenious spread?
What do you think, Yellow, or others? Well, I think that I agree with the comment that it's an unusual pattern of disease spread, and the thing that would make me think is, am I sure that this is first of all, a few things. Am I sure this is a primary and not a metastasis? Am I sure this has originated in the adnexa and not the uterine body, the endometrium and uterine corpus? Because yes, typically it's surface exfoliation is the pattern of dissemination. But we do see, we absolutely do see this in high stage serous cancers, and I think it does portend a worse prognosis for, the solid visceral metastases like liver mets and nodal mets. And maybe that's manifesting. You said her CA125 was on the rise.
Yes. It's actually higher than when she had surgery.
Sorry, say that again.
Her CA125 is actually higher than when she had the tumor removed.
Yeah. So maybe another sort of talking point is in the setting of bilateral ovarian disease with tumours that aren't massive. I mean, they're sizable, but they're not enormous. And you're contemplating the possibility that this is metastatic rather than primary disease. What's your approach there? What are the features that help you delineate or favour one over the other? And anyone can participate.
Sorry, Dr. Karen, what was your question again?
So when you've got bilateral ovarian masses, which is what we have in this case, and they weren't enormous in size. I think, I don't know, were they about 10 centimetres at the most on the left?
Yes.
You do need to contemplate the prospect of metastatic disease from another site. And I'm just wondering what macroscopic and histologic features you use to help make that decision if you don't have immunohistochemistry available to you. And if you do have immuno, what stains help determine primary versus metastatic tumour in the carcinoma context?
Well, you've mentioned one of them, obviously, is the presence of vascular and lymphatic spread as being something that would raise the suspicion about metastasis.
Yep. And obviously bilateral bilateral smaller tumours is more typically a pattern of growth you'd see in metastatic disease versus unilateral large tumour. So right off the bat, when you're looking at a specimen, if you see bilateral disease and they're less than either 10 or 13 centimetres, depending on which publication you read, that's more predictive of a metastasis. It's not absolute, though. I mean, obviously, you can have bilateral epithelial malignancies and bilateral borderline tumours. Yeah, so size and laterality. Any other thoughts about when you're approaching the macroscopic specimen, what clues might make you think about metastasis?
The capsule is intact in...
Yeah, the capsular appearance. So in this case, it's a very smooth capsule, isn't it? It's not got multiple tumour deposits and nodules on it. It's a smooth serosa. Yeah, and that's a feature. So smooth primary and nodularity, multifocal nodules, metastasis. And then histologically, we've mentioned extensive LVI. Any other clues? It's all part of about a metastasis landing on the ovary, the pattern of growth. What would you expect?
Metastasis.
Well, if it's coming out the tube, you're obviously concerned about, the hilar orientation of the tumor mass. That's one consideration. Also, if you've got evidence of a primary tumor or a suspected tumor elsewhere, as in the endometrial cavity, that's obviously a place you have to think about as the possible origin. And there, the depth of invasion and character of the tumor in that location obviously is something that has to be considered as a possible source as well, very commonly.
Yeah, agree. And also, multifocal deposits of tumour invading within a prominent desmoplastic stroma, things like the presence of signet ring cell morphology, which is unusual in ovarian primaries. These are, I mean, it's kind of intuitive. These are the sort of features you'd expect in a metastasis that's seeding from an outside of the female genital tract site. And then, of course, yeah, the other scenario is when we've got an endometrial tumour that might be transtubally disseminating to the ovaries. Does anyone else have any comments or thoughts or questions?
So what if this patient had a triple negative breast tumor, either synchronously or around the same time, maybe within the last year? Would that change your evaluation of this situation? Would you think of it as a metastasis more likely from that source?
Yes, maybe BRCA related.
Yeah. Yeah, I think anytime you're dealing with a possible tubal high-grade serous lesion, if they're going to want to know what her BRCA status is, especially if there's any family history or something of that sort. And of course, that's pertinent because obviously there are some alternate therapies that are open to someone with a BRCA mutation that you wouldn't necessarily go to first with just a routine high-grade serous. I don't know. Are PARP inhibitors available in Fiji?
No.
No. Okay. So probably a moot question then.
We usually get specimens that are really big, and then you have ones that have endometrial adenocarcinoma with bilateral adnexus showing similar thing. We usually, well, for me, are they two different tumors, or is it metastasis to the ovaries, or from its ovaries to the endometrium, or endometrium to the ovaries? Not that it makes a difference, but yeah.
I think that is one of the most common questions that comes up in tumor boards is this the endometrium? Is this the ovary? And of course, the the setting is often the same for the driver for both types of tumors is hyperestrogenism. And so then you have to sort of go with softer factors like, is there endometriosis present? Is there some other reason to assume or to point to one direction or the other as being the originating tumor? Size of the ovarian tumor doesn't necessarily make a huge difference in that situation because they can become quite large even when there's a smaller endometrial primary. But then you're looking more at depth of invasion, lymphatic invasion, orientation, bilaterality, et cetera, those kinds of questions. And even then, we don't always know. And so what do you do as far as staging? And I think that depends a little bit on kind of what your oncologists want to do. Obviously, if you stage it all as endometrial tumor with metastasis to the ovary, that's a higher stage as opposed to a stage 1A of the ovary and a stage 1A or 1B of the endometrium. That has quite a different feel to it in terms of prognosis and outcome for the patient. So I think that's where you sort of have to go on the softer factors like endometriosis present or history and so forth. I don't know, how do you manage those cases, Karen? It seems like it's a very common question in our tumor boards.
Yeah, so we're talking, I guess, mostly about endometrioid adenocarcinomas here when you have synchronous tumors in the uterine body and in one or two ovaries. And our approach prior to FIGO 2023 update in the endometrial carcinoma staging was to rely on all of those features you've mentioned and to try and I guess that is still our approach to some extent now, but to try and determine based on depth of myoinvasion and precursor lesions, whether the tumour in the, and extent of LVI, whether the tumour in the endometrium is likely to have metastasized to the ovary, and then out in the ovary, presence of endometriosis, as you say, in a benign or borderline tumour component, whether or not that's likely to have been a metastasis or a primary ovarian neoplasm, and try and sort of make a best guess about how we think this situation has evolved of having two synchronous tumours. Also looking at the tumour morphology. Do they look the same? Are they the same grade? If we have an MMRD tumour, do they both have the same mismatch repair abnormality? So we would try and interrogate that question by sort of weighing up the features of each individual tumour and trying to make a best estimate as to whether they're synchronous primaries or metastasis. I think a couple of things have changed or have informed that decision. The first thing is that there has been some literature published looking at molecular studies of these tumours and showing that the vast majority of tumours coexisting in the uterine body and the adnexa are clonal, supporting the argument that in many cases it's probably transtubal migration, exfoliation of an endometrial tumour, spreading via the tubes, landing on the ovaries and then growing in the ovaries. So it's probably in most cases, this is the conclusion that's been reached in the literature at least, probably the case that most tumours start in the endometrium and spread to the ovaries. And because of the pattern of that transtubal spread, the tumours don't behave as aggressively as you might expect for a high stage endometrial tumour, in that it's not invaded via myometrial invasion, direct extension, or lymphovascular invasion, getting to the ovaries in that way. It's more just exfoliation. That's the first thing. The second thing that's changed is the FIGO staging in 2023 has given us an approach to staging these tumours so that we don't need to make that decision anymore about where did they start, which came first. Are they metastases? Are they synchronous primaries? We basically just assign a risk profile to it based on various criteria. Basically, if the tumour in the uterus is superficially myoinvasive, doesn't have extensive lymphovascular invasion, and the ovarian disease is unilateral and doesn't involve the capsule, then it's considered low-stage disease. And if those features are not present, then it's considered high-stage disease. So yeah, we basically now, or what I do is I give the FIGO staging and let that sort of determine or inform the clinician's decision making.
Thank you.
These have been very good questions. Any other comments or questions from any of our colleagues in Da Nang or otherwise that want to raise a question?
Hello, Dr. Lewis and Dr. Karen. I am going to the class today because I don't know the chance of the time to take part in the class. So this case is really difficult to me without immunohistochemistry. So I think the first diagnosis of me is high-grade serous carcinoma, but I want to differential diagnosis with many diagnoses. So like metastasis or lymphoma or melanoma. This is really difficult to me.
Well, you're fortunate to have a little bit longer menu of immunohistochemical stains to work with in Da Nang Oncology Hospital. Vilhelmina
Yeah.
didn't have that luxury.
Yeah. So I will use some immunohistochemistry to help me to diagnose this case.
So what would be your starting panel to use on this case, Dr. Han?
Yeah, I will scan RCK, WT1, B53, B16, part A, or GATA3, and some marker of melanoma like SOC10, SMB45, and F100. About lymphoma, I will send LCA.
Yeah. I think that would be a very comprehensive panel that would get you the answer one way or the other. Sometimes when I see these cases, I just do the confirmatory stains. I don't necessarily do all the differential exclusion stains. So I might just do a WT1, a P53, PAX8 or something of that sort to start out with. And then if any of those were a little bit off, then I might add the GATA3 or the SOX10 or something else to sort of exclude those other possibilities. Deborah, thank you for joining us. Sorry we messed you up with the time zone change in the US. Do you have anything you want to add in terms of how you evaluate those biopsies for high-grade serous-looking carcinoma?
I'm afraid I've come in way too late to have any idea what's going on. I thought I would just show my face to say, yeah, no, I didn't realize we'd switched until just now. But yeah, because I haven't seen the cases prior either, so I haven't seen anything.
Okay.
Sorry.
Well, we've had a very good discussion.
Yeah,
Good. I'm very
so I'm a little bit just say something that I was so admire you, Mela. Without immunohistochemistry, you can do that, and you can present us that I will learn from you. That in in my lab, not good. Not good. I think it's not enough. I see, but when I saw you, I feel I'm a little bit lucky, more luckier than you. So, like, have I learned from you very much. Yeah, thank you very much.
Yeah, I agree. I think we take it for granted that we can reach for the immunostains in a case like this. It must be really hard practicing on morphology alone. And that's when, it makes us think about what are the first principles? What do we do in a case like this to try and nail down the diagnosis? And I think it's useful to go through that process because we don't really go through those steps for those of us who have large immunopanels available. Yeah. It's amazing how much your morphology can tell you.
Hello.
Well, I often think that the best surgical pathologists are also cytopathologists, and you have the advantage of seeing it in the fluid and being able to from there see that those subtle details cytologically, and that translates into your ability to recognize things under histology circumstances that someone who doesn't have that full spectrum of perspective would pass over. And quite frankly, as we train new pathologists now, it's almost as though they want to know, what's the bare minimum they can do until they get the molecular results back or something like that. And it's there is a lot to be said for having that sound understanding of first principles on histology and morphology. The molecular changes actually, I think, are represented in those images and in the staining characteristics by virtue of the fact that we're seeing a lot of people being able to predict, which biomarkers are going to be positive based on image analysis or AI studied correlations looking at these images and molecular data. We've had some of that intuitive information in our visual memories, not always able to explain what it is. But I think a case like this today illustrates, how you you come to the conclusion that's clearly correct based on those morphologic clues that arise as you evaluate and look at things and begin to put the case together. Of course, we can always be deceived, and it's always nice to have the fallback of those things to find the variants or the unusual character cases that may need a little bit different management. But you've made us appreciate that skill today.
And actually, you just mentioned another feature in this case, which we didn't discuss, is the cytology. These were cohesive clusters, three-dimensional cell clusters, weren't they, in that cytology preparation, which right off the bat tells you this is a carcinoma or a mesothelioma. But, that's not the pattern of presentation in cytology of a lymphoma or a melanoma. So that's another really useful first principles teaching point.
So before we wrap up today, and Rachel, I'm grateful that you're here on this, and I extend my apologies for not making the time zone change in the U.S. more clear. But as I said at the beginning, we want this to be at the convenient hour for you in your local areas rather than what's, a fixed time in the U.S. So if you would like us to retain the same time frame that we were meeting in Fiji, Vietnam, New Zealand, and so forth, we will adjust the echo timing on the remaining sessions back an hour rather than having moved it forward as we did with the
Thanks,
time zone
Lewis.
change in the US. So
I think we're about to change too. I think Australia and New Zealand are about to change to out of summertime. So I think it'll actually, by the time of our next meeting, it'll work itself out again. And
okay.
Fiji doesn't have daylight savings. How about Vietnam? Do you have daylight savings time?
No.
No. Okay. So I think it was just an aberration, just a blip this week. So all good.
Dr. Han, are you okay with that, keeping it at 6 a.m. for you for the next few months?
Yeah, 6 a.m. or 7 a.m. is what is okay with me.
Okay.
Oh, yes,
Yeah.
it's quite early for you, isn't it? I mean, I can go an hour later if people prefer that. Do we
I'm
need to send
flexible.
another doodle poll around or
Well, when we met the first time with the people in Vietnam with Dr. Lin and Dr. Han, we met at 6 a.m. So I think they are used to getting up early. So
okay, great.
Yeah.
we'll stick with this time. And then who's on for presentation for next time? Dr. Ziep, is that you?
April.
Maybe silver soft texture soft.
Yeah, I think it's Dr.
Yeah.
Ziep.
Yeah, I will talk with Dr. Yip about the presentation next session. I think see on the road.
Okay.
Yeah.
Well, very good. Well, thank you,
See
everyone.
answer.
Very good discussion and excellent case. Wilhelmina, excellent presentation, good photographs. Thank you so much for your work.
Thank you
Dr.
so
Han.
much.
I'm sorry to
Thank
miss
you.
it, Philo. It was nice to see you in Sydney last weekend.
Nice to see you too, Dr. Rachel.
Vilo, that was an excellent presentation. Thank you. It was very clear.